All right, so guys, this is Dr. Randon Hall. He's going to be presenting today on some pediatric sports injuries and stuff. Pretty interesting presentation we got for us. He works mainly at the Avondale Clinic, seeing pediatric sports injuries, non-operative, right?
Yep.
He did his graduate degree from Vanderbilt, right?
Yep.
Vanderbilt, and then you did your residency at Vanderbilt as well. And he's also from New Jersey, went to Rutgers, which is cool, so we just figured that out. And you're a soccer player.
Yeah, yeah.
So, anybody have any questions before we get started? Or?
All right, like you said, I'm Randon. Feel free to call me Randon. And just jump in if you have questions. This is kind of, like people say, it's always interactive, and then they never let people interact. So if you have something related to another patient that you saw or what have you, just jump in. If you want it a little bit darker, this presentation is all x-rays, but what we're going to do is talk about the clinical aspect of really of what that x-ray shows, how that kid will present. And what I wanted to focus on a lot was if you have someone getting better, you have someone that's not getting better, but they say the x-ray is normal, or they say there wasn't a fracture, or they say there was a fracture, I don't want you to get led down the wrong way, because we get sent a lot of people to us that say, he fractured his heel, he had this crazy injury, and that's really not what's going on, and the x-ray kind of leads us one way or another. So just want to talk about sports medicine related issues that are specific to pediatric, and then I want to talk about some of the things we see a lot in terms of pediatric patients getting treated like an adult, or if they come into you with a certain diagnosis that really doesn't make sense for a kid. And then I was wanting to just do this through x-rays, because you guys probably don't get a chance to see a lot of x-rays, so you get a chance to see what some of this stuff looks like, and we'll go from there. And we're going to start off pretty easy here. So starting with the foot, we see this all the time. So this always comes into us as fifth metatarsal fracture, and it's not. So this is what we will call fifth metatarsal apophysitis. So when the growth plate is just injured, it's kind of like Osgood Schlatter's of the fifth metatarsal. The problem is that a kid will come in saying they have lateral foot pain, they'll get an x-ray at urgent care or an adult place, and they're told that they have a foot fracture. They put them in a boot, put them in a cast, hard sole shoe, and they go back to being active, and they're still having pain here. So they really haven't worked on the foot and ankle intrinsic issues, if they have flexible flat feet, because what happens is the peroneal brevis tendon comes down and attaches there and basically just irritates it. And you can see that sometimes there on the lateral as well. What they get sent in for is a fifth metatarsal avulsion fracture, which, if you see the difference, the growth plate runs parallel to the fifth metatarsal. The fracture is always going to be perpendicular to the fifth metatarsal. So and these are all kids that I've seen. These are all, from the last 9 months I've been here, these are all my x-rays except for one of them. So you can see that on the lateral as well. And we think now that, yes, the peroneal brevis does come down and attach here, but also plantar flat fascia is what comes and attaches here too. So this will happen in that inversion injury, and they'll have swelling over the lateral aspect of their foot. Typically for this proximal fifth metatarsal fracture, I'll let them bear weight if they want to. You can put them in a boot, you can put them in a hard sole shoe, a cast, whatever. I just tell them if it hurts, don't do it. If it doesn't hurt, you can walk on it, run on it, have a good time. In terms of the fifth metatarsal apophysitis, I'll talk more about, just work, or I'll send them to you guys to just work on foot and ankle intrinsics. If they need a orthotic, that may be helpful too. But sometimes we'll see that, and they told us it was fractured 12 weeks ago and they're still not better because they really haven't gotten the treatment they need. So I just wanted to show you here, this is the healing of that kid's fracture, and he was just in a boot for 4 weeks and then progressed to a sneaker after that with no issues. So this is another thing that we see all the time. They come in and say, hey, the bone underneath their big toe is broken. And this is classic bipartite bipartite sesamoid, the patella of the foot. And basically they're going to present with those same symptoms that you see guys with for sesamoiditis, but again, they're going to be treated as a fracture. So what ends up happening is they get put in this shoe, they get put in this boot, and then their foot gets weak, their lower leg gets weak, and then they go back to activity because it's healed, and then they come back with the same symptoms because they weren't treated appropriately. So we see this all the time, and basically we treat this the same as you would for any sesamoiditis. You know, if they have pain walking on it, you can boot them if it's severe, but you can also just put them in a little donut, or if you guys cut a foam underneath the first metatarsal, and call it a day with that, and that should get better just fine. But again, that's not a fracture. You can fracture your sesamoid, or you can have a stress fracture of the sesamoid, but typically you don't get this clean, crisp line. If you have a fracture, there's sharp edges. So you can see, well, I can see up here, but you can see that it's rounded. Both of these two pieces are rounded, and that's not what a fracture looks like when it happens. So we have to triage a lot of these things too. So then kind of going a little bit more proximal, just a routine stress fracture. So this is a girl that's been having foot pain in gymnastics for about 3 months. But the thing is though, the x-ray's going to be normal in some cases. So, you know, if you have someone that gets sent in, let's say 13-year-old gymnast that has foot pain, and they say the x-ray is clear, well, that doesn't necessarily mean they don't have a stress fracture. You know, you have to make sense of the level of activity that they're doing. And in sports, we know, you know, gymnasts are in there for 30 hours, 20 hours a week. It really doesn't make sense that they have plantar fasciitis if they have tenderness both on the dorsal and volar aspects of the foot. That's how I kind of differentiate out. If they have pain on both sides of the metatarsal, then I'm thinking more stress fracture. You know, most people don't like it when you push on the plantar surface of their foot, but if you push on the top of the foot and it hurts, and the bottom of the foot, that's more bony than it is soft tissue. So this is the same, this is this girl's x-ray, totally normal on x-ray. We get the MRI, her second metatarsal has a stress fracture, and the lateral cuboid has a stress fracture. So she actually had some chronic issues going on, and I don't necessarily put these guys in a cast, or excuse me, yeah, I don't put them in a cast, but she had some issues going on for a long time, so we casted her, and then we may try a bone stimulator if she's not getting better. So this is another kid that just happened to, I don't have his original x-rays, but this is what it will look like healing-wise with a healed third metatarsal stress fracture. And again, you know, if someone comes in with that as their diagnosis, or you think it's that, they get sent back to us, we repeat the x-ray, we'll see that there's new callus or new bone formation there. So that's what it will end up showing, and sometimes it gets missed. It's foot pain, metatarsalgia, what have you, and then it actually ends up being a stress fracture. But once it gets to this point, it's healed, and they can basically do whatever they want to do. So this we see a lot as well. You'll see that at the second through the fifth metatarsal, the growth plate is distal, but the first metatarsal, the growth plate is proximal. But if you don't look at kids' x-rays every day, we have kids that come in all the time, they say they have a broken first metatarsal. It's not broken. They get put in a boot, they get put in a cast, come back, they still have whatever issue that it may be going on when they come out of the boot, because they were treated for a fracture. So whether it's a os navicularis or posterior tib tendonitis, that's what may be going on as opposed to a fracture here. So I guess I put that in there just thinking, you know, if you get a kid that's sent in for therapy after casting, or hey, they have foot pain still after being casted, you know, it may not be a fracture, it may be something else that was treated as a fracture. So that comes in pretty commonly. And then this is the pretty classic os navicularis. So that's that little ossicle over the medial aspect of the foot. Posterior tib comes in and attaches to the navicular. And that's not a fracture either. We get that sent a lot of times for fracture of the navicular. I treat this the same way I will with posterior tibialis tendonitis. In some kids, if they have flexible flat feet, we'll get them in the supportive arches. You know, the brand I use is Super Feet, but that's just what we used at Vanderbilt, so I don't know if you guys have ones that you guys like. You know, I try to give the families different options because, you know, Super Feet are 40 bucks or whatever. But I also tell them to bring their shoe to the place because, you know, they have purple, the blue, the green, and sometimes the green that has the higher arch hurts their foot. But otherwise, I'll send them to you guys to work your magic. But you can do surgery on these two, and it's really straightforward surgery. Just one incision, flick out that piece of bone, and sew it back up. Everything else should be pretty stable. Now, these two are connected, though. There's a fibrous union between them if you were to get a CT or an MRI, but that fibrous union can just get aggravated. So they'll have an inversion injury or just chronic foot pain and say, yep, I have a broken foot, get treated as a fracture, or just have chronic pain and come in and say, and you can see that os navicularis. Most people will have a good prominence there, so a prominent navicular, but not everybody who has a prominent navicular has an os navicularis, but just something to think about, especially in the young guys. This one you won't see as much, but it is something that we see. So this is a kid that won't bear weight at all. And I know you guys know about toddlers fractures in the distal tibia, but we also get toddlers fractures in the scaphoid, excuse me, the cuboid bone here. And for me, I can see that there's this white sclerotic area there, and that can just be a little buccal fracture or a little tiny fracture in the cuboid bone. Basically what these kids will come in and they won't bear weight. They jumped off of something and landed and won't bear weight. Not that you really see that many in PT, but they get sent in for x-rays, and basically the x-ray, foot, leg, upper leg, hip, because they won't be able to tell them where it hurts. And then you'll see this on the foot, this little small buccal fracture of the cuboid bone. You know, for these, I'll just tell them, we have little boots, those Wee Walker boots. I don't know if you guys have them here, but little tiny ones that'll fit their foot. And then we also, we'll just say, when it doesn't hurt, they'll walk on it, and it'll be fine. So we don't really hold them back too much. So believe it or not, I probably see this once a month as calcaneal fracture. You have to jump out of a plane, jump off a building to fracture your heel. You know, kids, they don't just, well, they tripped off the bike and their heel broke. That doesn't happen. So this kid, I mean, I'll give this kid, he was going in off a scooter into like a skate park, and the scooter jumped off and he landed directly on his feet. He had pain over his heel, but he went to, I forget, a podiatrist maybe for follow-up, and they said he had a calcaneal fracture and got sent to me for a new patient fracture. You know, the one thing is just get an x-ray of the other side, you know, so if it looks the same on the other side and it doesn't hurt, then it's not a fracture. Otherwise, you know, you can see the soft tissue here. There's not a lot of swelling there. You know, this is not a calcaneal fracture. So that little line there and this here is all normal segmentation of the growth plate. So again, if you get a kid coming in for a calcaneal fracture, or, you know, after casting, it most likely was a bone bruise and they have severs or something other than a calcaneal fracture. I've never seen one in all the time I've been a doctor, a kid with a calcaneal fracture. So going on to the ankle. So this is a normal ankle here. This is a AP and mortise view, so just a little bit of an oblique view. And what you'll see in these guys is people have ankle sprain and they're just not getting better, or it's swelling up. So they've been fine, but they go back to activity and it swells up on them. You don't typically get mechanical symptoms like kicking, clicking, catching, or locking, but you'll get, really what I key on is swelling. And if they're telling you, hey, it's been a year or it's been 6 months, it's most likely not just an ankle sprain with those two. And so this kid Can you guys see that little faint? Can you guys see back in the back? Okay, you see that little faint black area there? So that's what a OCD looks like on X-ray. Not every kid who has an OCD will have positive findings on the X-ray, but if they have this kind of chronic swelling or chronic pain, and it doesn't make sense, like they've done PT, why do they just go for a jog and it hurts? You got to think about an osteochondral defect. And basically you're looking to make sure that this cartilage over the top is still intact. Most of the time we treat these non-operatively. Basically, I hate this diagnosis because you got to shut them down for like 3 months. So what we'll do is basically no running, pounding sports for 6 weeks, bring them back, repeat the X-ray, and then at 3 months we'll get another MRI because we get an MRI initially, and then see what they look like at that point. If they haven't improved at all, they'll get surgery. If they're improving or healed, then we just let them go back to activity at that point.
Do you usually boot these?
So the data out there says that you will, like if you just read in the textbook, it'll say to boot them. If they're not having pain and it's just this swelling, I don't boot them. But if they say, yeah, it hurts to walk, then I'll boot them for the first 6 weeks or 4 weeks or what have you. But I don't cast them. And I allow them to wear weight bear. And then this is just normal fibula growth plate, normal tibia growth plate. And sometimes we see, I don't know if you can see that little dip up there. That gets sent to us as a fibula fracture, but it's really just normal growth plate. But you can see that there's a lot of little lines, little things. If you don't look at kids' x-rays every day, you're going to call something not an x-ray, you're going to miss something. Like this is pretty subtle if you don't see them every day. And this can happen traumatically, or it can just happen without, just over time. Some people say it's due to kind of pounding, but not necessarily. And this is what it looks like on MRI. So you've got this white, that's edema in that area. This is a little cyst formation. And then this is that osteochondral lesion, so the bone is injured here. But the good thing is that white line across the top is the cartilage, and that looks okay and healthy. So we're going to treat that non-operatively. And I just saw that kid back at 6 weeks, and he seems to be getting better, no complaints. And some of the times about the boot, the parents are like, well, we just want to do everything we can to make it so they don't need surgery, and they'll want the boot, which is fine, but it's not really necessary. This is another one that we see with ankle sprains. So just like that os navicularis, you see how it's smooth and round? That's not a fracture. That's just a normal part of the medial malleolus that didn't fuse back to the larger fragment there. And in general, this will just come in as like an ankle sprain. They can injure the fibrous union between these two, but I would treat this just like an ankle sprain. They can bear weight as tolerated, get them back to range of motion, weight-bearing exercises, and they should be able to progress back like any other ankle sprain. So sometimes when they come in with this, oh, there was a little chip off of that, it's not necessarily that, it's just a normal growth plate ossification center. So this is what we call os trigonum. A lot of people have them and aren't symptomatic, so this is what you'll see those guys with the posterior impingement, gymnasts who are landing short. It's kind of an incidental finding, but if they're having posterior impingement signs, it may be due to some impingement over the os trigonum, and sometimes people do have inflammation or irritation back in that area, but in general what we do is kind of the same thing in terms of sending you guys for therapy. They can be injected. Wilson, Vaughn, and I don't do a lot of ankle injections, but you can certainly inject steroid in there to get it to calm down. But sometimes the family will say, yeah, they said I had an extra bone there, and it's not technically an extra bone, it's just an enlargement of the posterior process of the talus there. So not a lot in the lower leg, but just wanted to show you guys that sometimes things get missed on x-ray. So you can't see the fracture on here because you're not able to see it, but if you got someone sent in, like a younger kid, maybe 2, 3, 4, for not wanting to walk, and the x-ray was normal, a lot of times those x-rays are normal. This is the AP, the lateral. There's no obvious x-ray, even if you, fracture. Even if you zoom in here, there's no fracture to be seen. But then what I did was treat them presumptively for a fracture, brought them back, and you can see that now you can see the fracture line as the body's starting to heal, and you can also see that there's callus formation, this little thin line that runs along the side. So that's your typical toddler's fracture, the little 2 or 3 year old that, you know how this happens most frequently? They're on the slide with mom, they go down on their lap, and when they hit the end, their foot gets caught and twists to the side. So that's what kind of causes a spiral fracture of the distal tibia. You know, it's not going to happen in an older kid, but you know, if you're sent someone that has, you know, just not wanting to bear weight, that's typically, if the x-ray was abnormal, or excuse me, if the x-ray was normal, most often it needs to be repeated at some point to make sure it's healing. So jump into the knee. So I just wanted to give you two pictures of normal tibial tuberosity. Okay, I know I sent one tibial tuberosity avulsion this way, but that does not happen frequently. Okay, if somebody says, hey, I play basketball and my tibial tuberosity hurts, it's not a fracture. It has to be, hey, I was running, cut to the side, heard a pop, or felt something pull, and it swelled. You know, if someone has a story for Osgood Slaughters, and they didn't, or let me say that, and they're said, oh, they come in saying that they had a fracture, it's not a fracture. It just can't be. So this is normal knee x-ray. This is normal knee x-ray. Both of those are okay. It's not very common that someone has a fracture of their tibial tuberosity. So this I just threw in kind of on a side. This is an osteochondroma. You know, you may have someone that's just saying, hey, I have medial sided knee pain, and they're coming in for pes anserinus bursitis or tendinitis, and you kind of feel a prominence in there that maybe somebody didn't feel before, and they're not getting better. One of the things just to be thinking about is an osteochondroma. Typically for kids, they happen on the medial aspect of the tibia, and basically it's bony protrusion with a cartilage cap. That's where the osteo and chondroma part gets to. And this person will do just fine. Typically we MRI just to make sure that's what it is. But if it's bothering them and they're being treated for therapy, then we'll just take it off. But a lot of times I'll just send it and say, hey, let's see if therapy helps you. Sometimes it helps, sometimes it doesn't. So this is another thing, I think, just like the ankle, where a lot of times it can be missed pretty easily. A lot of times they're coming in for 1 to 2 years of knee pain, but if they're telling you, hey, it swells periodically, then that has to be something else. So it's not just patellofemoral if it swells periodically. And I asked them, is it a grapefruit swell? Is it water? Is there water on your knee swelling? Because everybody's knee swells. Everybody has some injury that their knee is swelling. It's just some puffiness. But right here, this is totally different than that, and that this is an osteochondral defect in the knee. So this is an OCD of the knee, and then this is a lateral picture of it as well. Same thing as of the ankle. We MRI those. Same thing, the 3 months. They're off from any physical activity for 6 weeks. Repeat the x-ray at that point, bring them back at 3 months for a repeat MRI. If it looks like it's healing, we let them go. If it doesn't, they'll need surgery. So usually they're down for about 3 months. So this is one I just saw yesterday, sent to me from West Valley for, and it's kind of interesting because they come in like this long leg, you know, cast or splint, and they said they have a patella fracture. So this kid tried to run, jump over a fence, caught the top of his foot, and landed directly on his knee. So I didn't want to bend the kid's knee at all. I wanted to they didn't bring the x-rays with them. But to be honest with you, this is a normal knee. Okay, you have growth plates at the bottom of your patella, just like at the tibial tuberosity, just like at the fifth metatarsal. This is what we typically see or can see in that Singed Larsen-Johansson, so apophysitis of the lower pole of the patella. So I think he just had a bone bruise. We generally don't use knee immobilizers. I probably used one or two in the last 9 months, but we did put him in a little knee immobilizer just for a couple of weeks, just to get this to calm down, because he said it hurts to bend his knee. But in general, we don't do that. But this is not a patella fracture. So again, you know, I guess what I'm getting at is if you have people coming in with a diagnosis of status post whatever, you know, and they're not getting better with therapy, it may not be what that fracture was thought to be. It may be something else going on, you know, if you see those x-rays frequently. So this again was something I saw last week. So this was a kid who was playing soccer, right-footed, playing it with his left, and somebody came in, hit the left side of his, or the lateral side of his knee. So this was called a normal x-ray. He was put in a knee immobilizer and got to me 2 weeks later. Which, there was no harm done, but this is not normal, okay? Can you guys tell that this is pulled back a little bit? Yeah, so they call that normal. This is a Salter-Harris 1 of the proximal tibia. Again, you know, this might have been one, he had a large effusion. This might have been one that got sent to you that, hey, knee effusion. You know, I guess I was going to call this talk eval and treat, because I know there's a lot that get sent that are just eval and treat knee pain. So, you know, he had an effusion, so he probably would have gotten an MRI in the diagnosis, but, you know, he might get just sent for knee pain, x-rays were normal, and if it's a 10-year-old kid, that may not be the case. And here you can see there's just a little increased widening of the growth plate there, but this is definitely pulled back a little bit. There shouldn't be this space in here. If this wasn't there, I'd say, oh, maybe that's questionable, but also the amount of swelling that he had. So I got a couple pole vaulters and long jumpers that came in. So this kid, though, I think was actually quarterback in the fall, but this spring he was doing track, running the 100, 200. So he's just running, gets halfway through his 100-meter, feels a pop, you know, just falls to the ground. So basically, he avulsed his ASIS. So this is what that looks like. And you can see, you know, I know it because I've missed them in the past, and I've also just looked at so many, but you can see it's not all that, you know, it's clear when I put the big circles there, but if you're looking at multiple x-rays or you don't see a lot of hip x-rays, you may miss that subtlety there. So this is actually him 4 weeks out. So the way I treat them is just crutches until they can bear weight, and then get them to PT, and then just have you guys do what you do. I love when we have these talks and they ask, like, well, what exercises would you have them do? And we're like, we'd have them go to PT. So I think someone asked Vaughn at one of our talks about, like, they had a good shoulder program, but did they have some for the hip or something for that? And he was like, he tried to, you know, fumble his way through it. He was like, but basically we have PT take us through that. But yeah, so in general here, I don't make them non-weight bearing. I put them on crutches until they can walk without pain, and then just allow them to progress as tolerated. Usually I tell them they're back within about 4 to 6 weeks, and that shouldn't be a big deal at all. This is a 4-week x-ray showing pretty good callus formation. If you compare it to the other one, you'll see that there obviously was no callus. They're very tender over here on on physical exam, and in general too, just kind of I get them externally rotated and have them flex at the hip, and that'll kind of activate more sartorius and see if that will bother them a little bit too, coming off of there. So then this is a kid that we saw on Wednesday. So he's a pole vaulter, and said when he was planting, he felt a pop, and this is what his hip x-ray showed. So you see that little tiny thing there, that little fleck? That's a little avulsion fracture of the ASIS. You can see it's not on that side at all. The other thing I wanted to bring up is a lot of times these kids will be told, you pulled a muscle. So that's what this kid was told. He pulled a muscle. Well, you know, in general, the treatment is fairly similar, but it's not the same. You know, so they're going to have a lot more active stretching that may not be what we want them to do in those first couple of weeks. So this can get a little bit good callus formation and settle down a little bit. So, you know, in general, little kids like 8, 9, 10-year-olds, they don't really pull a hammy. Okay, they pull the bone off of their ischial tuberosity, and we'll see an example of that. So this was a girl, 14-year-old cheerleader, just doing a split and felt a pop. Went to the ER, took x-rays. They said the x-rays were negative and was told she pulled her hamstring. Now, you know, that don't look right to me. The family was the one that said, we looked at the x-ray and it doesn't look normal. Now, they say that a lot because there's all growth plates and all that type of thing, but you can see this piece is obviously pulled off. It should be sitting up here. So again, treated it just like the other kid, non-weight bearing, or excuse me, crutch weight bearing, and then progress to full activity. So I'm seeing her actually this afternoon, and we'll probably start her back to full activity as tolerated. But in general, littler kids, the smaller they are, the less likely it's a hamstring tear as opposed to a avulsion fracture. And then this was her at 4 weeks after. So that was injury. This was her at 4 weeks, and then we're seeing her back at another. Okay, so this was a young lady that I saw for hip pain with running. And if you look closely, you can see there is a growth plate along this pelvic brim here, but you can see the spacing here is bigger than the spacing there. And so you can have an apophysitis of the pelvic brim here. You can also have an avulsion fracture there. So, you know, sometimes they may come in with abdominal strain or quadratus lumborum, but sometimes if it's, you know, if they come in with the diagnosis being more muscular, but you're getting more bony tenderness there, it may be apophysitis of that area as opposed to a muscle strain. And in general, you guys are going to treat it the same anyway, but just something to think about in terms of injury, because it also could be a little avulsion fracture there too.
Is point tenderness just your biggest?
Yes, bony point tenderness. You know, and if it's a hip pointer or something like that, you know, I'll give it some time to see. But in general, if someone's like, hey, I'm a crazy runner and I run 30 miles a week, for what reason I don't know, and they're having pain there, then you think more about an apophysitis. But that certainly can happen in someone who just goes for to kick a soccer ball. You can get that x-ray, they're very tender over here, and you can see that it's a little bit more space there than it is on the other side. So this is a little bit out of the sports medicine realm, but something that can happen in the younger kids, kind of the 7 to 9 age group, where they're complaining of hip pain or they're complaining of knee pain. You get this eval and treat. You have no real mechanism for the injury. It hasn't gotten better, and they kind of have a little bit of a limp, but they're not complaining of pain. You got to think about a skiffy here. So this femoral head, can you see how it's kind of, this is perfect position here, but this is kind of slipped off a little bit. And just a simple hip x-ray would be beneficial for those kids, especially if you have one that's just, they just have this little limp, and the parents will say, oh, well, you know what, he has kind of been walking funny for the last 4 weeks, but we didn't pay any attention to it. Think about sending them back for a hip x-ray. Same thing, a little bit older kids, sometimes in overweight folks, same kind of presentation, but you can see the femoral head here is jagged and not smooth. This is AVN of the femoral head here, and that also needs to be kind of on your differential in someone that doesn't really have a good mechanism. They have this mild limp that they're not complaining of too much pain. So just something to think about. So I think I'll finish with wrist here. So this was a kid I saw earlier in the year for football. Came in with snuff box tenderness. Scaphoid was totally normal on x-ray. I treated it though because he had tenderness there. Comes back, and sorry you guys can't see this, but there is a thin little line here. That's his scaphoid fracture, so easily missed. So someone who may be coming to you with wrist pain or wrist sprain, you know, they may not be that if they have persistent scaphoid tenderness. Think about a missed scaphoid on the x-ray. So if they say, yep, the x-rays are normal, but they still have snuff box tenderness, you got to think about that. That's a scaphoid until proven otherwise.
It's usually just like that. Is somebody just wait a couple weeks and refer back? Is it usually shows up a couple weeks?
It shows up a couple weeks later, yeah. And sometimes it may not even show up then, and I would get an MRI. If someone has persistent scaphoid tenderness, you know, at 2-3 weeks out, if they don't have any signs on the x-ray, I'll get an MRI. Or if they're just like, I'm okay just to treat it, I'll put them in a thumb spike, a splint or cast, and see them back in a month.
How often are those surgically fixed cages?
I haven't seen any. This one actually was surgically fixed, but this is a different kid that I saw. Usually if we get to it soon enough, it doesn't need surgery. It's more about the displacement, and usually we're not doing enough high velocity stuff. But so this was a kid that was got hurt in baseball in the summer, and I saw him like November, and Dad was like, yeah, he's been complaining of wrist pain for 5 months. So this is what happens if you don't treat a scaphoid fracture. So this is a cyst that's developed here in a non-union of the two pieces, and then there's avascular necrosis. So basically he needs a pretty significant surgery on this, but it will be fine. But so I referred him on to the hand specialist. And I just wanted to show you guys just some subtle things in terms of people who come in for wrist sprain that may not be. So like, can you see this little bump out there in that ulna? That's fractured. It's easily missed. Sometimes we don't see it until you can see that there's new bone. See, there's no callus here, but there's some callus formation here. So, you know, if you guys are like, hey, that's more bony, you know, it feels bony to me, but the x-ray was normal, you know, it still could be a little buccal fracture. This is a little bit more obvious, but a lot of times they're a little bit more subtle and just missed. I think the good thing is you can't go wrong with this. You could put tape and a popsicle stick on it and just let them do their thing and it will heal. But, you know, just something to think about. Again, this is one very, very subtle. So you look at the AP view, everything looks okay. But can you see how there's a little bit of space in here? And you can't see it as well, but this piece is a little bit slipped off the back there. So that's your Salter-Harris 1 of the distal radius. Easily missed. But again, if you're like, the swelling just doesn't make sense, this is bony, you know, none of the tendons are sore, none of my tests are, you know, it may be something that needs to be reevaluated or at least looked at the x-ray again. So this is the one that wasn't one of my x-rays, but this is what gymnast wrist looks like. So basically you get some sclerosis of the distal radius. That's that chronic stress reaction of the distal radius, and you're getting a little bit of widening of the distal radius growth plate too. We typically shut them down, so either a cast or a brace for 4 weeks and see how they're doing afterwards. But again, someone who comes in with wrist pain in a gymnast, you know, that really may be what's going on, even if they call the x-ray negative. This is a little kid just with a little ulnar styloid fracture here. He had a distal radius fracture that's healed, but sometimes these styloids won't fuse back. It'll just be a fibrous non-union. So you can have a kid that may have had an old styloid fracture that's coming in for wrist pain and ulnar styloid fracture that was never treated before. Well, if it doesn't hurt when you push up there, then it's not fractured. You know, a lot of times like, the kids come in and I'm like, well, does it hurt there? No. It's not broken then. And then just a couple. So I just wanted to show you guys a normal elbow. You can imagine if you don't look at a normal elbow all the time, you're going to think everything's broken. So this is normal medial epicondyle. This is normal capitellum. This is normal radial head. And every view, the radial head should line up with the capitellum. So the green means good. Green means good. So this is our AP view. This is our external oblique view. And then this is our lateral view. And you can see radial head looks right at the capitellum. And then you also want to look at the anterior humeral line. So you come right down the anterior aspect of the humerus. It should go right through the capitellum as well. So that's how you know if anything's dislocated or anything like that. So this was a girl that was at the top of a slide, and someone had pushed her, and she fell on an outstretched arm. And you can see this does not line up with the capitellum, so that's a dislocated radial head. This is normal, okay? We get this a lot, that they fractured their olecranon, they fell, something like that. That's not what happened. If they weren't, the only one I've seen that was a fracture was a kid that was pushing another kid in football, felt a pop and huge swelling over the posterior aspect. So if they have pain back there, if they're a gymnast, it may be a stress fracture, it may be a triceps tendonitis, but it's not a fracture if it looks like that. That's normal growth plate. Then I wanted to also just show you some subtle radial head, radial neck fracture. So you can see that, hey, everything lines up, there's anterior humeral line is present, but there's a little nick in that bone right there, and that's all you see for this radial head fracture. They probably would be fine if you just let them go, but we cast them. So, you know, some of these people might come in for wrist pain or, you know, eval and treat wrist pain, but it may actually be a fracture that's very subtle. You can see here too, this is on a different slide, but you see this dark spot back here? That shouldn't be there. That's called a posterior fat pad, and that posterior fat pad should not be there. That means there's swelling or bleeding somewhere inside the joint. That's telling us there's either a fracture or an occult fracture there. And then again, this is the same kid, just a different view. You may miss that. So here is that posterior fat pad. Here's protrusion of the anterior fat pad, but there's no other x-ray findings of a fracture. So this person might get treated as elbow pain, but they have a fracture until proven otherwise with that amount of swelling in their elbow. She actually does have a fracture, but you just can't see it on this view. So this was a girl. Now this past like month or a couple of weeks, there's been a lot of gymnasts who have been in pain all season, but now it's regionals or states, and they want to know, can they participate? Well, this girl couldn't extend her elbow. She had significant pain. We get this x-ray, and this is obvious. This is an OCD of the capitellum. So she's probably had that for quite some time. She has swelling, she has a bony fragment in here. So again, she might have been treated as elbow pain or just pushed through it, doing some rehab for, just being an active gymnast, but she has injury to her cartilage there. In general, I would make this person just rest for 6 weeks. We told them the risks and said it's up to them. If they want to go, they can go. If they want to rest, they can rest. But knowing that you could injure the cartilage further, or you could break any more fragments off. It's not likely, but it could happen. And they went for it. She apparently was supposed to be the #1 going into it, so I don't know yet. Then this is just the last 2 x-rays. There's no pathology here, but just wanted to just let you guys see that this is a normal growth plate of the proximal humerus. Green means good here. So a lot of times we have kids come in with broken shoulder. We can see some widening there with Little League shoulder, but in general that's more of a clinical diagnosis. And then again, that looks like the ice cream fell off the cone, but this is a normal shoulder x-ray with a normal growth plate. So that's all I got for you today.